put it in a graph to pay for everything, right? Tuition and stipend, because someone has to live from it or something as well.
Yeah.
It's $250,000 to $350,000 in a grant. That's a total cost, and I think that's not. And I
It's
don't
a lot.
want it
Pounds.
to be honest, doesn't matter at this point.
Yeah. Yeah.
And at that level, so that's the.
Yeah, it's a lot of money.
I haven't solved it yet, but that's the problem.
I think the UK, just what I've heard, people sort of in Geneva thinking about sending their kids to London. Increasingly, they're looking for other options.
Yeah.
It's too expensive, even in England. Even in England, not just London.
So I'm Dutch. My wife is British. We live in the UK. When we're teaching our kids Dutch, like with intent, but that's partly because they're Dutch and need to be able to talk to their cousins.
Yeah.
It's also so that they can go to the Dutch education system.
Yeah.
Which is excellent for whatever you want to do with as a university and as a course at a global level. And the cost is like nothing compared to the UK.
I've seen people saying, well, we might go to Amsterdam, we'll go to Italy. Portugal's not an option, but I think some of the universities in other European countries have adapted and are teaching more in English because this British market is now
inaccessible, but also it's unaffordable. It's insanely expensive.
Yeah.
For the value from a lot of places as well.
Yeah.
Until pay for Oxford, that's worth it in some stuff in Imperial, some courses, but the vast majority is not worth it.
Well, my daughter found this summer school. She's 16. She found this summer school in Oxford next year. She told me how much it was. I said no.
Not worth remortgaging. Mum does get a PhD, you get a summer school.
Sort of like £6,000 or something for 2 weeks.
It's a money model. It's just
yeah, exactly. I just said no, you can find something else. So she found something else. There's something in Tanzania.
That's more fun.
So, which is, it's still not. You have to pay for it, of course, but it's much more affordable. So you can go to Tanzania, but you don't need to go to Oxford. No. She said, it looks good on the CV. I said, I'm sure it looks good on the CV.
My house looks good on
real life. But I couldn't believe how much it was. I said, how long is it? She said, 2 weeks. I went, oh. She said, it's the accommodation as well.
My wife went to my neighbour. They have like 8-week terms, right? They call them something fancy anyway. Yeah. But they're kicked out. They have to leave and vacate their room on site, their dorms. They have to vacate them so that Oxford can rent them out, or for like $6,000 per 2 weeks. Yeah. To run their courses.
To rich kids' parents.
Sufficiently. Yeah. So, anyway, what are you doing aside from adolescent TB? I'm assuming you've solved by now.
No, we haven't solved it yet. So our team works on TB, HIV, comorbidities, and vulnerable populations. So obviously all the guidelines around comorbidities, that's the other main piece of work with Annabelle. So we just published mental health. Yeah. Then we're adding HIV, which will come out before the end of the year. Okay. Then we'll add diabetes, and then of course we'll add undernutrition. Good. Okay. So Cool. So that will take, it will take time, but and Annabelle's mainly leading that work.
So I'm not completely blank. Did we talk about mental health in the PhD? No, sorry.
I don't think so. Is that someone else?
Yeah, but
I don't think so. No.
But I think so mental health we are. So I think one of our team, our group went to the mental health. Did you go to the mental health working group?
No, I couldn't. I couldn't go to nutrition working group either.
Because
Annabelle went.
Okay, because we're looking to just acknowledging and seeing it's a problem, just to try and start engaging and do some exploratory modeling just to see.
Oh, I see.
Where it might, I think we know that it affects certain aspects of the natural history and care cascade. It'd be nice to. Okay. If that's what you're going into, or
well, just send us anything that you're doing. Any papers or
Well, this is starting a paper.
Right. Okay. Yeah. I'm not going to read this, but I thought I just need a few notes for a 5-minute talk.
I wrote my 2 pages out.
Did you? Yeah.
I highlighted them bold to try to keep track of them.
Yeah, me too. Yeah.
5 minutes, right?
Yeah.
Have you got anything else on after this?
Just this meeting on TB in prisons.
Yeah.
And then just a few other one-on-one meetings with people. And I think there's another symposium, shorter regimens, if I can get to that, and then KNCB 120-year anniversary.
I should probably have a look at that.
You should.
When is that?
6:30 to 8, and it's
Okay.
here. It's here.
Okay.
Yeah.
In this one? Okay.
Yeah.
I might look on that.
6:30.
I did my MSc internship at at London at KTV. So
Right,
I started
okay.
with Frank Covenant.
Yeah.
Is that like presentations or is it?
I think there are some presentations, and I think there's also like some food or something.
Okay.
Yeah.
It's a bit tricky. We've got our group outing, the watery thing happening. this evening.
Oh, have you?
Yeah.
Right.
So this
Yeah.
is even,
Yeah. At some point,
testing in social stuff.
at some point, you need to
online.
network a little bit. Yeah. Yeah. Oh, where's number 2?
Are you joining us, Goodman? Are you? I feel watched by you. I feel watched and judged by you at the same time.
Where's Guy? Guy's meant to be here.
Yes, I do.
So how do we know who's a journalist today?
I think ask nice question.
Yeah. Okay.
Hello, sir.
Guy, I did see Guy actually. He was
I've seen
just
him today.
He's everywhere today.
he
So
was
he's
sitting
fine.
in the
He's
Community
just,
Connect.
Just finishing the
Right.
Community Connect one, so it might be.
Yeah, I saw
couple of
him
minutes
down
late.
at yeah. That's fine. Do one fact check. What's the time? That's 1:30 now.
Hello, sir.
Hi, how are you? I'm good.
How are you?
Yes.
Hi,
Good.
how are you?
I'm good. Good. Nice to see you
Yeah,
here.
you too. You too. Very nice to see you.
Just get started. In 2 minutes.
Let's pick up.
Yes.
Where's Guy?
Elsewhere. Not here, I think. The main call
Who's going to start? Alex? You go.
I'll start, yeah.
You'll start, yeah. Okay.
I was just going to give Guy just a couple of seconds to see
Yeah,
if he can,
yeah.
how fast he can run.
I saw him. He was literally a few steps away. He wasn't far away. Yeah.
Yeah, that was like 10 minutes ago.
Yeah. Yeah, it was. It certainly was. He's had time to get here, but he's probably just caught up, I guess. must be needed everywhere, Guy.
There's always someone busy in that.
Of course,
It
yeah.
feels busy, but
Yeah.
there's always.
Is there not many journalists?
Yeah, I don't know how these directors and
Yes, so we've had.
how they manage really, but
Journalists registered.
I guess they're well supported, so people support them.
Virtually, so we've got people.
I imagine that there's choices being
on
made.
YouTube.
Yeah, of
And
course.
having to
Yeah,
be-
that's why I'm here, because
So I'll be able to get the questions out.
Oh, okay.
Yesterday, a lot of
Okay.
questions.
Yeah, so
Get started. We'll get started. So, welcome everyone to the third press conference of the Union World Conference on Lung Health 2023. Thanks to everyone for joining in person and online. I know there's quite a lot of people on YouTube and the conference platform, so welcome to everyone for joining. My name's Alex Metcalf. I'm the communications lead at the Union, and I'm delighted to have the panellists here. We've got some of the most exciting research and also the latest updates from the TB and lung health community, so thank you all for being part of this today. In terms of the format, so each of the panellists will have 5 minutes to give an overview of their kind of work, and then followed by a Q&A session with you in the room, but those online as well. So just a reminder, either put your hand up and we'll bring a mic round, or if you'd rather use the QR code to type your questions in, and those on YouTube, obviously, write your questions in the comments section, and we'll deliver them to the panelists. So we'll start with Kerry. Is that okay?
Sure.
Thank you.
Yeah, great. Thank you very much, Alex, and hello everyone, and hello to everyone online. My name's Kerry Viney. I'm a team lead in the Global Tuberculosis Program at the World Health Organization in Geneva. And I'm going to talk about the WHO roadmap towards ending TB in children and adolescents, which is this very nice mango-coloured document here. And this document, in fact, was launched here at the Union Conference on 14th of November, so just a few days ago. It was launched at the annual meeting of the Child and Adolescent TB Working Group, and this group was actually instrumental in working with WHO on this document, and you can see the logos of the other major contributors on the cover. Now, getting back to the roadmap, this is actually the third edition of this document, the roadmap towards ending TB in children and adolescents. The previous two editions were published by WHO in 2013 and in 2018. This is the 2023 edition. And the aim of this roadmap is really to define the actions that we need to prioritise, not just as WHO, but as a global TB community, to prioritise and implement over the next 5 years to reduce TB-related morbidity and mortality in children and adolescents. Now, the roadmap is fully aligned to all of the global targets. So they include, of course, the targets of the End TB strategy, the Sustainable Development Goals, as well as the targets that were set very recently at the United Nations High-Level Meeting on the Fight Against TB, which was held in on September 22nd in New York. So this roadmap actually features the new UN HLM targets. Now, the structure of the document is as follows. First of all, we take stock of what is happening with regards to TB in children and adolescents. That includes a testimony from a young girl who had multi-drug resistant TB at the age of 11. Her name is Kiara Goslet. She's from South Africa, and it outlines her story and her journey with multi-drug resistant TB, which was really a family story. It wasn't just her story alone. She was infected, unfortunately, by adult relatives, and unfortunately one or more of those relatives died due to TB. We then have some very nice infographics with the latest data from the Global TB Report, and the Global TB Report was also just published just a week ago. So we have some really accessible and friendly infographics that can be used in media. We summarised the progress made against the key actions in the second edition of the roadmap, which was published in 2018. And we then talk about some of the persistent and new challenges that prevented achievement of the 2018 UNHLM targets. And then finally, to sort of take us forward instead of looking backward, we have 10 key actions to address these challenges, and this is our roadmap for the next 5 years. Now, in terms of some of the remaining gaps that have been identified, they're organised into 4 main categories. So they include insufficient prioritisation, funding and accountability, the persistent and I would say stubborn policy practice gaps to develop, implement and scale up programmatic approaches to detect more kids and adolescents with TB, weak implementation of strategies, so family-centred strategies, people-centred strategies to access TB care, and the persistent data gaps and shortfalls in research and development. Now, finally, I would just like to say that the thing that really takes us forward are the 10 key actions in this document, and that's really the roadmap part of the roadmap. That's what is taking us forward over the next 5 years to further reduce morbidity and mortality related to TB in children and adolescents. And they're summarised under 4 themes, and I'll just read those themes out. So the first one is to increase political leadership, multi-sectoral engagement and accountability, and to sustain advocacy, and there are a number of key actions under that theme. The second one is to address the persistent policy practice gap. So we often have policies that are developed, but they may not be adopted, or it's difficult to adopt and implement those at the country level. The third one is to strengthen the implementation of integrated people, family and community-centred strategies as part of primary healthcare, because children, particularly young children with TB, are often presenting at the primary healthcare level. They're not going to the tertiary hospital. And then finally, the fourth one is to address some of the persistent gaps in data and also some of the shortfalls in research and development, so we can adopt some of those latest innovations and apply them to TB in children and adolescents. So this all has to be done, of course, in partnership with all of the stakeholders, communities, civil society, the affected families and the children themselves. So I would strongly encourage you to have a look at the roadmap. It is available on the WHO website already. It is our blueprint or our roadmap for further reducing TB-related morbidity and mortality in children and adolescents over the next 5 years, fully aligned to all of our other WHO documents as well, such as guidelines, operational handbooks, and a new e-course that will soon be coming out for the management of TB in children and adolescents, designed for healthcare workers, because a lot of capacity building is also needed. Children and adolescents need a little bit more attention often than adults to actually find them and diagnose them. So I might end there, and happy to, of course, take any questions related to the roadmap or related to the data on TB in children and adolescents, or related to other aspects of WHO's work in this area. Thank you very much.
Thank you, Kerry. Rain, are you okay?
Thank you. Yes, quite a shift. So not a guideline, but more science to hopefully implement, affect guidelines. So our work basically deals with the issue that we've known for quite a long time, that current TB policies are not bringing down TB incidents as much, or let alone as fast as we thought they should. And our work quantifies just why. We've shown that likely over half of transmission is being missed by the current passive system before it starts even begin to work for patients. And more than a third of people who might have infectious disease never even make it to the system. So for most people with TB, we still wait for them to recognize symptoms and seek care at the clinic, and then hopefully they can receive a diagnosis and care. And the expectation and hope was in the past that by recognizing symptoms and then becoming infectious, infection basically happened at the same time, and this passive system would then do 2 birds in 1 stone by preventing death from TB, but also stop transmission. However, most of that turns out not to be true, and our group at the London School of Hygiene and Tropical Medicine, funded by the European Research Council, is working to estimate just how much transmission we're missing with the current policies.
And the first problem that we're facing is just wherever we look, we find that between 35 to 80% of individuals who are likely infectious don't report symptoms when asked. And other work has shown these individuals are likely to be contributing to transmission. So the big question then became for us, like, what happens to these individuals? Are they all going to get clinical disease later on very quickly? Or do they linger, or do they recover? And if so, how quickly? And that's something we can't actually study now, because these people should and do now receive treatment. So what a group did is troll through 100 years of TB studies and data to put things together. And with the resulting data, Alex Richards and Catherine Horton were able to establish the pattern of pathways people take after MTB infection. And that work's been recently been published. And that brings us to the work that Ty McCaffrey is presenting later today. And I just want to note that that is work in progress and is not yet submitted for peer review. So in that work, Ty asked 3 simple questions. How much transmission occurs before people with TB even access the current system? Does the transmission come from subclinical clinical disease, so when they do or are not aware of symptoms? And how sensitive is the result to some of the assumptions that we still have to make because the data isn't perfect? To answer those questions, we take the observation that most people, when they then finally do receive care, say that they already had 2 months of symptoms on average. There's a lot of variation there before they receive their diagnosis. Putting all that together in a model, Ty then ran 1,000 simulations of 10,000 individuals to see what happens to them after infection and track their disease pathways over 10 years. And then we can track whether or not people are reaching the care system and when they reach the care system. That allows them to tally up how many months they spent in the disease states and quantify how much transmission occurs in each group and also with what disease type. The final key assumption we have to make is how infectious these individuals who are not reporting symptoms are. And we took the somewhat conservative estimate there, about half is infectious, but explored that further in sensitivity analyses, because we're scientists, we try to be careful as we can be. With those model inputs, we find that approximately 57% of all transmission comes from people who are not reached by the current system. They either never develop the systems that brings them to the clinic, or they've already spent a long period of time being infectious before they even reach the system. We also find that about 54% of all transmission comes from people with subclinical disease who are not really represented or served by the passive system that we are currently still operating. In our sensitivity analysis, we found these proportions remain high and in a relevant way, even with if we assume the relative infectiousness is lower than half. So with those conservative estimates, we find that over half of transmission comes from before a person seeks healthcare and would be included in the current framework, which would explain to a large extent why the TB burden is not declining at the pace that we thought it would if we diagnose the number of people that we're doing now. Now, the results are the benefit of a lot of work where we can now finally start to quantify and understand the different pathways that people take over time when they develop TB disease. And we're now able to analyze that and start to answer some of these questions that are, we think, really important. Just to say again, these results are in the early stages, and we're now focusing very hard on getting the work written up and submitted for review. But please do come to Ty's presentation. We hope with our work that we can shift the TB policies and start making sure they address the needs of patients as much as they can. And we stop waiting for them to get so ill they have to come to a clinic, and instead find and treat them and provide the treatment they need so that we not only help them, but also stop transmission and make a serious dent in TB burden. Thank you.
Thank you, Bain. Tara? Thank you.
Thank you, Alex. I think it's really the two of the earlier speakers highlighted the key issues, what we need to do. Actually, the key issue here is how to break the chain of transmission of TB in our community. How to do this? I think that we need to find all TB cases early, put them early on the right treatments, and help them during the course of the treatment. And also, it's our the job not stop there. We need to have a follow-up after completion of the treatment. I think these all things need to be in a system. So earlier this month, we had the conference in Goa, India, and several civil society organizations came together with the support of the Molvayu Diagnostics and several other private sector as well. in India. So the call that has been endorsed by over 200 organizations and individuals from more than 30 countries. And key issue, a key call is very simple. Find all TB and put all of them in the right treatments and diagnose them with a modern diagnostic tool, molecular test. I think that was the key message of the global call. So what we discussed during the summit in that conference is we have the global, TB is a global agenda. So there are several high-level meetings, there are many declarations, the global, the WHO, the guidelines, the policies, all are there. But we need to translate all of these at the local level. When we see the global picture, it's a global target. And then when you come to at the national level, at the country level, national, like for example, Indonesia is a big country, over the 270 million population there. I don't think we can achieve this. No, those targets, those goals, we need to further break down at the local level. If you reach at the community level, at the local level, then that you have the population, small population, that can be managed easily at the local level. So when we reach at the local level, actually there is no target. There is no target. We have to find all, and it's possible and doable and feasible. So I think the whole the global agenda now need to translate it at the local level, and we need to, when we talk about find all TB, it's not only health sector, it's beyond the health sector. We have to come up with a whole of government approach and whole of societal approach. What do I mean by the whole of government approach? It's a health ministry or health department or health center is not only one to take care. Of course, they have to take care about treatment side, but when you go at the community level, we need to engage all the sector of the government. And whole of societal approach means now we are, even in this conference, I see our more of focus is more on the treatments, diagnosis, and still we are within the box. We have to go out of box. That is, there are people without TB, they have their right. How to protect their right to be exposed to the, their TB. So therefore, we need to protect the right of the people with TB and also right of the people without TB. So if we engage the people without TB, I think we can bring everyone together, and we can bring all the TB people in a system and put them on the right treatments with the right diagnosis. I think that's the key message that I would like to highlight here. So again, in summary, local action, I think really is needed. We need to break down the national targets at the local level. And that's the key. Engage the local political leadership, that is mayors, governors, or at the local levels. So they manage their community, they know their community, and they have the capacity. They have the capacity to bring everyone together for better care and better services.
Can I just make a comment on that as well? Sorry, I came in late, so I'm Guy Marks. I'm the president of the union, and thank you, Tara, for that. Very good. And Tara himself has done a huge amount of work on developing local capacity at the city and municipal level in tobacco control to some extent, but also for tuberculosis. And he made a very important point here, is that we have all focused entirely on, or almost entirely, on people who have TB and their immediate contacts. But in fact, we have not focused enough on the rest of the community who don't yet have TB and who don't want to get TB. And what can we do for them? They have rights too. And we need to focus on the rights of protecting people, the whole community, in high burden settings,
from having TB. I've given the analogy, and the problem, I think, is that fundamentally in high burden environments, people don't recognise that they're getting infected and that they're getting TB from having been infected. The analogy is tobacco and lung cancer. In a country or in a place where everybody, 100% of people smoke, it does not appear that smoking causes lung cancer. It appears that lung cancer is a genetic disease. The only reason we know that smoking causes lung cancer is because we can look at people who smoke and people who don't smoke and see this huge difference in the risk. For TB, in low burden settings, it is incredibly obvious that you get TB from being exposed to somebody with TB. Nearly everybody you get some reactivation of remote past TB infection, but the majority of cases of TB occur due to somebody having been exposed. If you're living in a high burden setting, Vietnam, India, South Africa, everybody is exposed all the time. It's as if everybody was smoking all the time. So most people don't recognise that they're actually getting TB through having been exposed to somebody. And that's why it's tending to be ignored as the driver of TB. But it is the driver of TB. You get TB in a high burden setting because you've been recently exposed to somebody with TB, usually within the last couple of years, sometimes within the last few months, and we need to stop that. And there's only one way of stopping that. That's by finding and treating all the people who have active TB, infectious forms of TB. With COVID, we tried to do the same thing. But with COVID, we didn't have any treatment. The only way we could stop, we had to find people with COVID, but the only way we could stop them from infecting other people was by isolating them, by putting them at home in quarantine. And we used to have to do that with TB. That's why we had sanatoria. But since 70 years, we've had treatment that can rapidly render people non-infectious. That is the huge advantage of TB treatment, the huge advantage we have in TB, that as soon as you start on treatment, you become non-infectious to other people. But the key is to find all of these people. We can't just rely on people presenting with symptoms of TB, and we can't rely on just looking amongst so-called high-risk groups, because most TB in the community occurs in people who are not members of high-risk groups and who do not have significant symptoms, who do not have symptoms that drive them to a diagnosis. So the only way to find everybody is to actually screen everybody with a test such as radiology or a molecular test to make a diagnosis and then get them onto treatment quickly. And that's the strategy that we're talking about here. And so just to come one more thing from what Tara was saying, he's talking about targets, which is, that the targets are not, national targets for the number of cases you find are actually, well, they're better than nothing, but they're not actually the right target. The target is the number of people you're prepared not to find. How many people are left after you've done your screening? That's what should be the target. How many are we prepared to leave in the community infectious? So we need targets for that. We need to be able to measure it. It's not that easy, but you can measure that sort of thing. There are epidemiological approaches to doing that. But we need to move from targets for the number of cases found to targets for the number of cases not found. That is what is actually relevant to preventing transmission of TB disease. So I think that there's a paradigm shift in thinking needed here, and we're trying to advocate for that.
Thank you.
Sorry, Tara, I've taken up some of your time. Okay.
Thank you. Honour, over to you.
Thank you. I'm Monirod from Cambodia. Yeah, I'm going to talk about lesson learned from our project in Cambodia. So, target active case finding should be prioritized in setting in the low case notification This is a lesson learned from Cambodia that we implement native care finding among minority group in Cambodia. So you know, Cambodia remain on the global TB watch list among 30 high burden TB country, 30 high TB burden country. So nearly half all TB cases were estimated to be undiagnosed and treatment in Cambodia. This like, for example, in 2022, around 32% is the missing case. So I think it's from like among the most like hard to reach people that we cannot detect the TB case. I don't know why. It's really like maybe our service provider or the patient themselves that we didn't like find the TB service, because through our observation from our project called Commit that we implement together with 4 organizations, with CANA, CAC, ASD, and from Qatar, Cambodia and Tuberculosis Association. So we implement just around 3 operational districts, about 20 age community. So it means our mobile care finding to the 28 event. It means one of active care finding. So we screen people age 50 and older, age 55 and older, among about 8,000, more than 8,000. So if like check X-ray abnormality, we ask them for a sputum for test by GeneXpert around 1,190. So the case that we detect 440 TB cases include like nearly half bacteriologically positive. It very significant. About 78.6% of TB patients were age 55 and over. So it means old people is most vulnerable with TB. We also see that more than half people that we screen is female, but the case notification like in male 58% is more than female. So this our project implementation. We compare. We just find the result that we call the area that and the result from Global Fund project. So that's why they didn't select the community, because the rate report notification rate is very low. So we implement active care findings. We can detect like compare to the trend, like 5-year trend of the TB is 370%. So it means that additionality very high. We estimated that around more than 300 patients that is absent active care finding is they can say that they didn't receive the treatment and care. So we have like the thing that we didn't understand that Cambodia provide TB service for free of charge, but why is still like a large missing case? I think one more thing is like about we use like the modern technology, like modern tool for screening, like UK finding. We use the digital X-ray, and we use the gene expert. We can attract to many people that don't want to visit the public health service. So it attract to the people that we call it the missing. Yeah, the thing that we need to understand. And the last, I think, the active care finding should be priority in among two area that is low notification or hard to reach people. Thank you.
Thanks. Thank you very much. Interesting. My name is Goodman Makanda. I'm a TB survivor. Let's first fix one thing. You don't call me a TB case. People living with TB. That is a language that is, I think it's acceptable. I'm a TB activist and a TB survivor from South Africa. But I so wish I was engaging one-on-one with this when you finish the presentation. But my colleague cover most of the things. It's what I'm always saying. We, as a community with TB, we always put ourselves in the box. That's why now of these days we don't have more TB survivors to come forward and share their story, because we're always looking for people people that they have TB. But TB is two things: you either infected or you are affected. So if we can call all of those people, as you say, we only meant looking for close contact to the person that is living with TB in the household or in the community. But what about the community at large? And it's a problem of the implementation and the guidelines that are sometimes coming up from WHO, not including the community at broad. It's always putting the people in the box. If we can fight for that, we've been fighting for, I will make example for 3HP TPT to be available for everybody. But our guideline was saying from 5 years and 60 and above. That was a problem. Who's this in between here? It's no people in between. So, the infection you mentioned of how can we bring these people on treatment early than to spread the disease in the community. One, if we can make this or guideline compulsory when you visit a healthcare facility like HIV, you go for headache, but you will end up at the HIV room. Why you can't end up to the TB room? Why we're isolating TB? And we always say TB is a disease that always opportunist. When we will be ending TB is the time when we will make sure when we acknowledge TB as a disease itself. Not to say because of you having this, you must have this. That is the thing should be away on our mind. And another thing, I like the book because, and the lady you mentioned I was mentoring the lady to become a TB activist at the University of Stellenbosch. She is also here. I hope she was also here, but I think she's busy somewhere. The roadmap, we're always neglecting those community. That is our future. We're always focusing, even when the medication, betaquilin, teleminate, linezolid is out, and now we talk about BPL, but where's the BPL for the children? We improving the roadmap. What is carrying on the roadmap is what we should be asking. The roadmap is there, but what is inside when it comes to medication when you talk about this roadmap? And I so wish I can go through this involving even the rural areas that we are having children in, because Western Cape, I will make example for Western Cape, we have people, they stay in the farms of Stellenbosch, that is outside where the suburbs, or the site of we staying in Cape Town. So we need all of this data collection, go to the community. I was busy, the guideline was out about THP to be available to everyone now. But no consultation was done to the community. No implementation plan. We still hang, the guideline was released, I think 3 months or 6 months ago, but we're still standing. We don't know where we're going to get THP. I consult people living with TB, living with HIV, community at large, community healthcare workers. You will be shocked what I find into this community. The community, the TB survivors, they know TB, they want to take THP. But the community healthcare workers, they ask, now you are bringing more burden on our healthcare facility to have extra files and what. But where is the implementation plan? So WHO, when you're releasing all of these things and you write this nice guideline roadmap, but what is the implementation plan? Let's have a plan before we release something. We know from here when we release the book and then what is going to happen next. But we have sitting down in the nice room there with clothes, and then we come up with a good idea that is going to work. But how? You will end up now sitting there on the cabinet with a dust because no one going to use. So I think if we work together and call, as you say, grass, break it to, sorry, to the lower level. Hear their needs. Listen to them. Take and compile on what you know and what you heard from them. And then make a solid decision that will be fitting everybody. Thank you very much.
Thank you, Goodman. Guy and Kerry, would you like to respond to Goodman's comments?
You should speak.
Yeah, sure. I mean, just to respond to you, Goodman, I think, of course, the role of communities is vital. And in terms of, our process for developing either this roadmap or any other WHO guidance, communities are very closely involved. So particularly for the roadmap, we engage with our WHO Civil Society Task Force on TB. We engage with other community members. We have a very, very strong country representation. And in fact, we had a consultation for this document, and the core team members reflect, civil society, affected communities and countries. You can see that we also engage Kiara in this one. I fully agree that we don't want documents that sit on a shelf, whether the shelf is virtual or real. They need to be adopted, taken up by countries, and implemented. That's where the rubber hits the road, so to speak. And I think the 10 key actions in this document are designed to be a bit more about the how. Now, the countries will adopt some of that and decide how they want to do it. So whether we say key action 1, for example, is about increasing detection of children because that's the biggest gap. So countries can take the tools that are recommended and try and improve the detection of TB in children and adolescents. But I do agree that the communities are crucial, and we're involving communities, affected communities, civil society and countries quite strongly in the development of our documents, and trying to issue documents such as rapid advice and rapid communication to also prepare countries for changes. But I agree with you. It's actually critical that And the community should also make noise to demand services. So it's sort of a two-pronged approach. But thank you. Yeah. Guy, did you want to?
No, I don't think
Okay.
I've got anything.
Yeah, of course.
Yeah.
to add.
I just want to add one more thing here. Yes, we have all these technical guidelines, and the both at the global level, from WHO, and also for at the national level. In my opinion, I think these all technical guidelines need to be supported by the legal instrument. To build the accountability of the governments, local governments, all the providers, and also the community as well. Look, for example, if I am diagnosed with the TB, I have also the responsibility. I need to be responsible for my house, for my household, and for my family, and also the community. So I need to behave, right? So at the same thing, also for the community as well. So all these guidelines, I think, is really needed to back with the legal instrument at the country levels, even at the local level. So I think legally we need to mandate the TB control. I think it's really important, the legal instrument. Yeah.
Yeah, I agree, Tara. I think there's always a balance here between public health and personal health. For all non-communicable diseases, which in many countries is what people are most used to dealing with, actually. If you've got cancer or asthma or diabetes, there's only one person affected by your illness, and that's you. And so a decision by the individual, the decision about whether to accept treatment or not accept treatment is an entirely personal decision. With airborne communicable diseases, particularly with airborne communicable diseases, which is COVID, influenza, measles, and tuberculosis, the people who share the air with you also have a stake in your illness. Okay? So if I have tuberculosis, it's my problem, but it's also the problem of Kerry, who's sitting next to me here. If she has tuberculosis, it's her problem, but it's also my problem. So we can't look upon tuberculosis, unfortunately, as simply the problem of the person who has the disease. It is a problem for everybody else as well. And we have to somehow come up with a way of balancing the rights of the individual for care and for decision making and for their own life with the rights of the other people in their community who share the air with them. And that is often a challenge, but it's not an insurmountable challenge, and one we need to recognise and take on board. Sometimes we've tended to, in TB communities, we've tended to sway far too much in one direction, and probably in the past we've had the public health focus too much and ignored the rights of the individual, and other times we sway too much in the other direction and ignore the rights of the community. And we need, in fact, to accommodate both in a balanced way, like many things. Sorry, Kerry.
I think Tara has a very valid point about the legal infrastructure, if you like. And I think for countries, of course, when they come to the World Health Assembly, there are resolutions that they sign up to. There's also the recent United Nations High-Level Meeting Declaration, which was just published 2 months ago, and countries have committed to certain things and achieving these targets. So then they need to prioritise this at the country level. It needs to translate into action. So, thanks.
Can I clarify a bit? So actually what I mean, I fully agree with you. Again, all the UN, the declaration, WHO guidelines, all, we need to go at the country levels. It's considered, it's not a mandatory. It's considered as like a voluntary, There is no legal mandate. So when we talk about really if we want to make the elimination of TB, I think we really need a strong legal instruments, and that to support all the technical the guidelines for better implementations of the programs, and also there should be a mechanism of the sanction. fine as well. I think it's needed. I think we have to think about this.
Well, many countries do have
so
sanctions, but many other countries don't.
So it's important. Like in a COVID, for example, of course, Singapore is a very small country, but they have all the legal instruments. That everybody has to be responsible, and those things. So if there is no sanction,
and it's the same in many countries for TB treatment. If you have TB, you are legally required to take treatment for it, and if you don't, you get locked up.
But in a high burden setting, there is, I think, in the very few countries there. I think we need to look at on that aspect as well.
Yeah, I know that's what you're getting at, and I think that is an issue but needs to be balanced against individual rights.
I mean, this might be where the role of sort of prime ministerial level or presidential decrees can come in, where the highest level leadership commit to doing something, which we've seen in sort of some countries such as India, Indonesia and Brazil. So, yeah.
And to that point, so with the UN high-level meeting recently, Goodman, how would you say we kind of involve the community in those kind of commitments going forwards?
I think to involve the community on this in a way forward in high-level meetings. Actually, some of them, they don't know anything when you take about LHM. Mm-hmm. We are those few who were lucky enough to know about it because I've been in the industry for so long. It's never been consultation around in the community in Bizo where we let the people know about these such a things. As I was saying, of some of the people, they don't know when you're supposed to get services like this and that, and then where to report such a things. So the lack of information, that is a problem that we are in between. So if we can having people that they can keep on conveying the belt from high level meeting to the grassroots level, so the people, they can be aware of such things and having opportunities to be these high-level meetings happening in their area that they will be maybe it will be easy to accessible, because you can't be talking about a high-level meeting but you're going to hold it in Geneva. You can't be transported. Even the community from Geneva itself is in the high city of Geneva, not in the area that people maybe they can be having access on. You see, things like that.
Thank you, Gimra. I just realised this has been really fascinating, but I've not even asked if there's anyone in the room, and I need to look at the online questions. Is anyone in the room got any questions they'd like to ask of the panel? If not, I can move to the online questions. That's fine. So, Rain, there's one for you here. So, the amount of transmission missed was reduced to a third if the study assumes a lower relative infectiousness for subclinical. Can you tell us why?
So this is, in the end, so this is a modeling exercise. So this is not a trial where we're doing this work, which is something we'd like to do, but this is to explore putting everything we know or what we think we know together. That does mean we need to make an assumption about how infectious people are who are not reporting symptoms, so subclinical disease. And so in the model we used a somewhat conservative value that's already at the bottom end of what we think the value is based on the data. Then we can make that even less, which does mean that all these months that individuals are spending having some clinical disease and not reporting to care, they are transmitting less as compared to the period they have clinical disease. So if we then compare the scenario where we assume it's half as infectious to a third as infectious, the total amount that comes from subclinical disease and the amount missed reduces. And the reason that the amount missed reduces is because that is dominated by people who are not reporting symptoms. Because if you are reporting symptoms, then you're likely to start going to care. But it's how much comes from these individuals who are not going to go to the healthcare system because they're not aware of the symptoms. That is the driver of how much we're missing in the current system.
Thank you. And one for you, Monarath. How do we implement active case finding more widely, kind of off the back of your study?
Yeah, we are working with the local authority and we have some mobile team, and we before our we bring the X-ray and gene expert. We have organized the orientation meeting with a local authority, and we invite all the villages or village health support group to provide them the knowledge on TB and how to screen the criteria that we need to select the people in community, and then they back home to screen from door to door screening, and then we arrange the date, time and location for our care finding, and we identify how many people that we need to invite for our event. So we screen we can arrange a week before the event that we can start. So I mean that before we work just only with the health service provider, it means the local health center, but the percentage of participation is lower than is working with the local community, local authority. Yeah.
I like the idea of how can we increase this, go forward for looking for more people that may be having TB in the community, and you talk about more going to the community, but more with mobile. Sometimes this mobile stuff, like I will specify of saying mobile, I take it as an X-ray that is been in the truck that is going to the, but we have those community that you can see yourself. Other countries, the car they can't even go in. How about the carable X-rays that can help? Because I think back in 2000, the time I was still working with MSF in South Africa, we have a portable ECG that you no need to go and visit a healthcare facility. You can just punch it in here and then it read all that's supposed to be. How can we make more things in this technology to be easier to access the community? What do you think about that? How can we working together, even the community, know and fight for that, for those things that are carable, that can be door to door? Because of the screening, what we're talking about, you can screen. We're having those people, they don't have any symptoms, but they are carrying the disease, as Rain was mentioning, of how to eliminate those infections. So you will find out in the household, you having good men staying in this house, but no symptoms of TB, but all the people in the house, they are having TB. As soon they start the treatment, but you can see the infection, it's not getting better, it's getting worse and worse and worse. Also, what do you think about the carable ones that can be in the community with the screening? Thank you.
Yeah, I think in our country, about the screening tool is not many in the hospital, especially now at the health center. Just have in the some referral hospital only, and the capacity building of the staff also cannot identify through X-ray, and it's not available for gene expert at the health center. So I think it's we have, you are right, we have like a portable, very portable machine. It should be have at least like some, for example, 3 or 4 health center have the central one for X-ray for the diagnostic tool that we need to refer the hard to reach people to get this research. I think it's better for early detect, and we can treat everyone early. Yeah, I think.
And then there's one last one, which is for the panel as a whole. What we've all, so the comments we've all heard, particularly with Rain's research in terms of like we're clearly not doing enough. What are the kind of 2-3 things that we need to do or see happen going forward to reach the 2030 targets? Guy, do you want to go first?
Yeah, I have a view about this. It may not be shared by everyone, but many people on the panel have heard my views about this. And I've already alluded to it in a way. I think we need to do more of some things and less of other things. I think we need to have a strategy for ending TB in high burden settings that is specific for the nature of the disease, for the epidemiology of the disease in high burden settings. The disease differs, the epidemiology differs in high burden settings from low burden settings in fundamental ways. One is that in high burden settings, by which I mean, well, in low burden settings, TB is by definition uncommon, and most people never get infected with TB when they have very low risk of being infected because they have a very low risk of being in contact with somebody who has TB. There are very few people in the community who have TB, so the risk of getting infected or reinfected is very low. In those settings, most cases of TB occur sporadically, and they occur due to the reactivation of remote past TB infection, which happens occasionally in people usually who've come from a high burden country to the low migrated, and they reactivate sporadically, and they may infect a few people around them, and the health system finds those people, treats them, and the outbreak stops, and there is no spread of TB infection. So in those settings, it makes sense to simply wait for people to present with symptoms, to perhaps do targeted screening, as we do, for example, for migrants when they come into the country, and perhaps that gives some targeted treatment for latent TB infection to people who are at high risk. In high burden settings, the epidemiology is entirely different. It does not occur sporadically. It does not occur in outbreaks. It's endemic. It occurs all the time. People are all the time being exposed, reinfected, and developing disease. Most cases occur due to people who've been infected recently, who've acquired the disease, who've been exposed or re-exposed and reinfected within the last few months to 2 years. And although some cases occur due to reactivation of a remote past TB infection, they represent a very small proportion of the total number of cases that are occurring. So in that setting, it makes no sense to give treatment for latent TB infection, frankly, because as soon as you've given somebody treatment for latent TB infection, they will, as soon as they've completed it, they will be reinfected, and they are again at risk of developing TB. It doesn't make sense to be investing heavily in targeted treatment for latent TB infection in high burden settings. It does make sense to do mass community screening to try and find as many cases of active infectious disease as you can, principally not for the benefit of the people you find, but for the benefit of the people who you can prevent from being infected or reinfected and going on to get TB. And we have some empirical evidence of this from study we did in Vietnam, and we now need, I think, to be scaling that model up and assess and doing further work to identify how it can be most efficiently and effectively implemented in high burden settings, and how it can be therefore scaled up and financed. There's a lot of work still to be done, but that's where we need to go. So we need to change, in my view, the direction of what we're doing, disinvest in some things and further invest in other things, which will actually lead to the end of TB. It is possible to end TB in high burden settings, and within a relatively short period of time. Certainly by 2035, hopefully within my lifetime, and well before the end of my lifetime, actually. I'm intending to live long enough to see TB eliminated. Okay.
Kerry?
Okay, thank you. Well, I think the first thing you need political leadership and commitment, and then that translates to lots of other things, whether that be funding or the legal aspects that Tara was talking about. I mean, you really need that commitment at the highest level in a country to say, this is a problem in our country, we're going to address it, and we want to see this no longer a problem in our country. So I think you really need that sort of high-level leadership, and as I said, that translates into many things: accountability, multi-sectoral engagement, the funding that will flow, the partnerships that need to happen, all of those other things that flow when you have a government that's very committed to addressing a major public health problem such as TB. And then for a number two sort of point, I think there are many other points that could be mentioned. If we're just talking about children and adolescents, for example, then you need healthcare that goes right down to the smallest clinic at the peripheral level of the healthcare system, where the community health worker is there, and they need to be able to detect TB in children and adolescents. So you need a healthcare system that's strong, TB care that is decentralised, and that's particularly important for children to detect more TB in children. Of course, it's important for everyone. But I would say, at least for children, that they're probably the two main actions: this high-level political commitment and having community-level services that can detect more kids with TB and get them into care. Thanks.
Thanks. I think, there's three things I think we need to do. One is, and we haven't talked about them, but if we make everybody solve poverty, nutrition problems, and also completely resolve HIV, a lot of TB problem will be gone all by itself. That's not in our purview, but that is one thing that we can be doing. The other thing is that then the next step is, and I do agree with Guy here, we need to screen as many people as possible for disease, and that will have a massive impact very, very quickly. And it's been shown both in trial with pre-screening and also in the trials that Guy has done. I would slightly nuance we do need to emphasize the benefit for the population, but there is a massive benefit for the people as well, because I think, not to speak for you, Goodman, but I think it's a good thing to be diagnosed early before TB ravages more and more of your lungs or your body, and there's the individual benefit of getting in there early. How we communicate that effectively and to enable people to make the choice to take treatment is a question, and that comes to my last point. We need to figure out, I think we know what we need to do. How we do it is a big question. It's a question of money, but I think a lot of it is also, and that comes back to Goodman, how we involve the community, because there's no way that medical doctors are going to be doing this. There's also no way, the scale we're going, that nurses are going to do this. There's not enough of them, and we're not going to train them either. This is going to have to be driven by people coming from the community, supporting for the community. Otherwise, there's no way we do this. Even with 10 billion, we're still not going to do this. The people who need to actually do this are going to have to come from the community in a way that works for the community. I don't see how we solve it otherwise. I don't know how to do it, but that's where I think we need to go. Full stop.
Thanks. Just to complement the Kerry's point, the high-level commitment needs to be translated at the local level. So local leadership is really key, because the problem is the local level. So building the local political will and also local, identify the local resources, that's the key point. The other point, again, I would like to re-emphasize that the legal tool needs to be developed at the country level that mandates the national government, sub-national government, private sector, individuals, and the community all to work together, for.
Okay. Agree that we need to set up a modern diagnostic tool at least one for one district, it means that to empower the community that refer hard to reach people to screen like without delay, I think.
Thank you, Chair. Thank you, President. That's it. Can you give me 1 second before I give what I think to ask the book about? I was attending one of the sessions today about children diagnostic. Diagnosis. They are using a gastro wash that we all know, but the challenge was these people. I want to know exactly what is the plan. But these people been trained and everything, and all of a sudden they remove for a greenhouse pasture. How are you going to keep them? Because you're going to invest through these people to do gastro wash in these children and all of those things. So how going to keep them to stay on these healthcare facilities as you having this roadmap that I think is another plan, but
sorry, just because time and the room needs to be for someone else.
Okay, sorry.
Are you okay?
Yes, only thing I can say, R&D, we need it in the TP. That's all.
Thank you, thank you. Yeah. Just say thank you all for attending here and online. This is the final press conference. Thank you to the journalists who've engaged a lot so far, and we look forward to seeing kind of the stories that are coming out from the conference more broadly across the globe. So yeah, a big thank you to everyone. Again, if there's anything that anyone needs, contact myself or Charlie over here. We can set up media huddles, we can do interviews online. Just let us know. So a big thank you to everyone, and thank you to the panelists. That was.
So can I also just say thank you to Alex and also to Charlie and the Lexington team for organising this over the last 3 days, and thank you all from me to the panelists and to the journalists both here and online for supporting the union. Thank you.
Thank you. Thank you all. Sorry, it's fine. Thanks so much for doing this.
You're going to want to do your session now. I'll see you there.
Hey, Monica.
That's okay. You're welcome, yeah. Hopefully it's useful. I don't know. Is there any other questions that came up?
No, we'll watch press conference and then I'll get in touch. So what we'll do is we'll get in touch. We have your email.
Yeah.
If there's any sort of
Thank you
interview
both.
request or anything.
I doubt that guys work.
Yeah, no, and are you here for the rest of the weekend? Or?
No, I'm going home on Sunday. Like my lifestyle.
You getting to do stuff?
Yeah. I live in Hove, so I just go going down.
You're in Hope?
Yeah.
I'm in
Okay.
So quite well.